As you place your implant, you're feeling and you're thinking.
Mhm.
If you feel like, it's got that kind of resistance as it's going in and it's not quite, you just feel like it's literally that feeling like it's about to talk out, but you've only just started placing the implant.
Mhm.
Don't just keep going. Stop, back it out, re-drill. Yeah. Don't just idly go, and then I'll just talk it right down, because people get very nervous and they don't, especially if the patient's awake. You don't want to be seen to be, taking out the implant and placing it again. And gosh, what are they going to think of you? Don't worry about any of that. Just make sure you do the right thing and think about, why it is that this implant just is, is tougher to place than it should be.
That was Dr. Dastaran. This is the Noobie Dentist podcast, and I'm your host, Dr. Omid Izami. Welcome to episode 2 of the Implant Audio Mini Residency, brought to you by my good friends at Mordent. I'm very excited. I hope episode 1 was filled with gems and nuggets of information for you listeners. If you haven't checked it out, be sure to check out episode 1 with Dr. Leighton Fu, which was implant dentistry for the general dentist. In this episode, which is episode 2 of a 5-part implant mini audio residency, I sit down with oral maxillofacial surgeon Dr. Dastaran, and we get into the surgical aspects of implant dentistry. From patient assessment to planning to the flap designs, osteotomy sequence, rationale for single stage or 2-stage implant placements, and much, much more. This is one of my favorite episodes that I've done recently, as I myself am very interested in the surgical side of dentistry and of course implant dentistry. So it was nice to get to have the opportunity to sit down with an oral maxillofacial surgeon and ask specific questions that I have in mind. And I try and put myself in the position of the dentists that are listening to ask questions that I think will be high yield for you as well. There is an accompanying radiograph, OPG, and CBCT slices that I will put on my website, newbiedentist.com, which we refer to throughout this interview. So if you want to check that out so you can kind of follow along, head over to the website and you can find the image there. In this episode, we talk about a lot of aspects of the surgical side of implant dentistry, and in the following episodes, I'll talk more on the restorative and digital planning side. So I'm really excited to kind of sequentially walk you guys through implant planning, implant placement, implant restoration, and implant maintenance. I'm really excited about this series, so I hope you guys enjoy it. This week's episode of the Mini Implant Audio Residency is brought to you by my good friends at Mordent. Mordent is your proudly Australian-owned and operated partner, driving the charge forward in integrated digital dentistry. Being the only fully integrated local dental company, Mordent offers world-class education, equipment, products, solution, and support. The Mordent team of over 50 specialists are helping thousands of Australian practices to seize the opportunities in digital dentistry, transforming treatment for their dentists and the patients alike. Whether you're seeking to upskill through education or are considering implementation of digital dentistry into your practice, or just looking for some advice, I highly recommend reaching out to the Mordent team. Visit www.mordent.com.au to find out more. I will include their information in the show notes for those interested. As always, if you're new to the Noobie Dentist podcast, thank you for checking us out. Be sure to head back and check out the previous episodes that I've done on the podcast. I've had the privilege of having some amazing guests on the podcast over the past couple of years. If you're returning, thank you for your ongoing support of the Noobie Dentist podcast. I hope this mini implant audio residency is full of value for you. And if you are getting value, please head over to iTunes and give the show a 5-star rating. These ratings help the show get more traction within the dental community. Without further delay, enjoy this week's episode. I'm joined this morning with Dr. Dastaran, who is an oral maxillofacial surgeon here in Melbourne, Australia. Thank you so much for being a part of this implant mini audio residency, and I'm excited to kind of get your take on the surgical side of things today and implant placement. And before we kind of get into all that, though, I'd like to hear your story and why you got into OMFS in the first place, and we'll take things from there.
Oh, well, thank you very much for having me, Omid. It's a pleasure. I studied medicine first in the UK, and it was while I was teaching anatomy to dental students at the University of Bristol that I, absolutely fell in love with head and neck anatomy. And being a purist, thought that, there's no better thing to do than to go back and study dentistry so that I can progress in my career as a head and neck surgeon, because it was this area that I was interested in. And when I finished dentistry, well, towards the end, I had an amazing opportunity to come to Melbourne to be, during my dental elective, to work as a locum senior registrar at the Royal Melbourne Hospital, which is a real coup. Definitely
awesome.
not an opportunity that would come around very often. So being me, I sort of, took the opportunity, even though I wasn't sure if I was going to be able to rise up to it, but I did, and was invited back the following year to take a position as an unaccredited registrar. And really, my love affair with Melbourne began then. And maxillofacial surgery was just seemed the natural progression from there, because having studied medicine and dentistry, and really being more interested in the hard tissues than the soft tissues, or the ear or the nose, Max Dax was really for me, as opposed to say plastics or ENT, for example.
Yeah, definitely. And Melbourne is a great place to be, having come here myself. It's definitely one of the better places to live in the world. So I'm curious, when you were in med school, were you like, what were you going to do initially before you kind of fell into like the dental head and neck path? Did you have like another career choice, or was it surgery still like another field of surgery, or?
Well, I enjoyed everything I did at medical school. I enjoyed medicine. I enjoyed general practice, but I knew that I wanted to be a proceduralist of some kind, because, certainly within the NHS, certainly if you have a procedure that you can do, it increases your employability, really. So, whether it was, echoes or, esophagoscopy or, whatever, but then I realized, I'm actually quite practical. My mother's a sculptress. So she's an artist and she's very good with her hands. I wish I had her, her ability to just look at something and sculpt it. But certainly I think I've inherited something, because, I'm very sort of, I like to work with my hands. And so surgery came from there. And then the love of the anatomy came from, teaching it. So, but really, I could have gone down any path because I enjoyed all of it. I love medicine, but then I studied dentistry and I loved that too. And I really, thought carefully about whether or not I wanted to practice as a dentist, having studied dentistry, rather than going back into surgery. But when I had the opportunity to come here, I don't, the journey was just wonderful, and it still is wonderful, and I wouldn't change anything.
Sure. So. And tell us a little bit about your current practice, sort of like what you're doing in your day-to-day procedures and what you kind of get excited for in your week.
Well, so I work in public and private practice in Melbourne and in regional Victoria. And I think I've been very lucky and very grateful that I do work in regional Victoria. And during COVID, I've actually been quite busy still, because the regional areas have still been working, been running, not, at 100%, but so that's really kept me sane. It's really been a lifeline, just as Melbourne is beginning to pick up. But I'm on call for the Royal Melbourne this week, and we're very, very much back to normal in terms of the trauma that we receive, and we're starting to get back into the elective operations, which is great. So orthognathic surgery really is my main love, and I always say to patients, you're in the right place, you're in the right city in the world to have your jaw operation, because people come from all over the world to train to do this operation. They come here to Melbourne because we're so good at it and we do so much of it, and I love it because it's so life-changing for the patient. But it's also, it's a little bit scary in that, you're taking a well patient and you're rendering them sort of unwell for a while. And so that, that's a slightly different mindset to taking somebody who is, who's, for example, broken their face in an accident and you're repairing it. So it's a slightly different mindset, but it's definitely my love. And then trauma I love because it's every case is different, and the face is just so important, both functionally and aesthetically, for somebody's psychological well-being. You have a huge part to play following a big trauma. So and it's like a jigsaw puzzle. The end point that you want to get to. You just have to get there as well as you can, as safely as you can. So it's the challenge that comes with every trauma case as well. And the decision making, often these patients have multiple injuries. They have a head injury or, other parts of their body. And so you have to communicate with your other colleagues in surgical and medical fields. So that makes it certainly more challenging and interesting.
Definitely. And I think that's one of the appeals of oral OMFS as a specialist, because it's such a broad range of procedures that you do. Like some of the work that you might do in private practice, which is maybe more in line with what we'll talk about today with like, implants and things. So that's one side of it. But then all the stuff that you get to do in the hospital settings with trauma and like the orthognathic surgeries and like all the oncology stuff and things, like it's just a huge kind of broad range of scope of skill that you guys kind of develop throughout your training, which is pretty exciting. So, as a part of this module that we're doing kind of 5 episodes on implant dentistry, and I'll be talking to Dr. Harry Schlen about sort of guided and technological aspects of it. What I was hoping to talk to you about today was more the surgical planning and like surgical execution. I'm not sure, and we'll touch on it, whether or not you do more of your cases like freehand versus guided and things, but just in terms of, just basics of surgery planning, flap design, and preparing your sites and placing the implant and things, we'll kind of go through that in a kind of sequential manner, if you don't mind. So in terms of patient assessment, so a patient walks in the door, they want an implant, say in the hypothetical case that we're doing today, like the 2.4-2.5 site, what sort of the initial things you kind of do in your workup and your assessment of the patient?
Well, certainly I want to know that their oral sort of disease or their oral condition is healthy and stable. And I think that's really important. And as I say to patients, if you can't maintain your own teeth, there's no way you can maintain an implant. Yeah. And I use the sort of car analogy. You have a car, you maintain it, you take it for servicing on a 12-monthly basis, and if you don't, it can fail and leave you in the lurch. And it's really important. And componentry might need to be changed over the years, and that's part of the deal. So I'm quite firm about that. So I get very nervous when people come. If they come, if generally my referrers are obviously really good and they've addressed all of these things, by the time the patients come to me.
Yeah.
And then obviously, is the site that's being chosen for an implant, or are the sites edentulous, or is there a tooth there, first of all? And obviously, depending if there's no tooth there, then you're looking really at the quality and the volume of the bone and the soft tissues. And if there is a tooth, how are we going to time the extraction? Is there infection present versus healing? And then how are we going to plan the treatment process, but also temporize? So if it's a front tooth, for example, then I'd need to speak to the restoring dentist to discuss temporization. That's really important. So there's a few things, but quality of tissues really, and am I going to be able to get the best? My ideal scenario is to be able to achieve a dental implant that looks like a tooth, right, in every way. And if that's going to be compromised, the outcome in any way, then I need to make sure the patient is aware of that
ahead of time. And what about in terms of like diagnostics, in terms of imaging or scans and things? What do you normally do as like a baseline in terms of your treatment planning?
Absolutely an OPG. And sometimes patients will come with a PA, and that's fine, because they might have seen an endodontist and they've had, very minute imaging, sort of very detailed, small scale. But I want to see the whole mouth. I want to see the opposing dentition, the jaws, make sure there's no underlying pathology, something that's been missed. And then I will assess the patient clinically before I organize any further scans. So I think that, nearly 100% of my patients will have a cone beam CT scan at some point, but that's not without me making sure that I'm targeting the scan to where the area that I want it. And importantly, if I assess a site as being deficient in bone, then there's really no point in scanning that site until, because it's not ready for an implant. It's clear clinically that there's nowhere for the implant to go. So then I will look at bone donor sites. So if I'm planning a ramus block graft, for example, I'll scan the ramus bilaterally, because that's going to tell me how much bone there is. and the distance from the nerve for harvesting.
Yeah.
So yeah, I mean, that's the thing that I emphasize to, my referrers is that if you're not sure, just send me the patient and I'll organize the scan. But certainly if you look at the patient clinically and you think there isn't enough bone stock, and that's why you're referring to me, I'm not interested in further scanning that site because I can glean that information clinically already.
Yeah. So that makes sense. So there's no point imaging the recipient site if you know it's not going to be enough bone anyway. So you just take from the donor site so you can plan your surgery that way and you do it. Okay. So how does your, so in terms of like, cause I want this to be like very practical. So in terms of your appointment breakdown, so that your patient comes in, they've been referred to see you for that implant. You take your images and you do your planning. Is the next appointment then for the procedure, or how do you what's your workflow appointment wise?
Yeah, pretty much. Sometimes though, I will have to have a conversation with them on the phone because they don't have a CT scan. So I give them the option of coming back. If it's a complex case and there's a lot of money involved, and then I do feel more comfortable with a face-to-face review. So I can actually show them the scan and go, this is what this is why I'm planning this. This is why I've planned your treatment like this. But if it's fairly straightforward, then I will just touch base with them on the phone.
Yeah.
And then the next appointment is a surgical appointment of some sort. So whether it's the extraction or the implant placement and guided bone regeneration, depending on what needs to be done.
Yeah.
And then obviously in between that, before that next appointment, I'll be on the phone to my restoring dentist, talking to them about their expectations and importantly, what implant systems they are familiar with and what their preferences are.
Yeah, there's a lot of communication. It seems like is very important, obviously, with the referring dentist or restorative dentist to make sure the outcome's achieved. So what we'll do is you've shared an OPG and a PA of like a hypothetical case that we'll kind of go through. This is a case that you did see yourself. So obviously, if you're listening to this as a podcast, I'll have it in the show notes. You can kind of download it and just have a look. Or if you're watching this on like YouTube or Instagram, then it'll just be on the screen so you can kind of go through it. I think this is cool because we can actually maybe approach it from both angles of, one is an extraction site that's already been there for a period of time. So you can just talk about it as if you're going to go ahead and place an implant. And then maybe like the 2-4, I believe, is like a previously root treated tooth that has an apical infection. So we can talk about extractions and different sequencing and things from that, if that's cool with you.
Cool. Absolutely. So are you going to put the picture up or did you want me?
Yeah.
Oh,
so
okay, great. There. So essentially, as you can see here, you've got the 2-4 space, which is there's obviously a tooth missing, and then the 2-5 is in root canal treated. Okay, the 2-5 is completely asymptomatic. So the patients come with an OPG, bearing in mind there's no other imaging. All right.
Yeah.
And so I'm looking at the patient clinically, and I'm looking at the space for restoring the 2-4 implant. Okay. Now we've got to remember the OPG is deceptive. It looks like the space is really narrow mesiodistally, but clinically there's plenty of space. So remembering as the OPG comes around the head, as the beam, X-ray beam comes around, it's sort of as you go through sort of the body area of so basically in line with the pupils, essentially this area here, the image is squashed, so everything looks much closer together. So actually clinically there's a lot more room for an implant there. So that's number one. Secondly, is there enough height? Is there enough width? So height you can sort of see there, but width you need to assess clinically. And certainly he had not enough bone clinically. There's a bit of a concavity, and you can see that on the OPG. If you look carefully, you can see a little cleft, a little indent along the crest. Yeah. Mm-hmm. So that you'll often see that on imaging if you look carefully. So clearly there wasn't enough width here, but there was enough height, which was good. So the patient needed bone grafting, and I felt clinically that they needed an onlay bone graft as opposed to just guided bone regeneration, because I want the best emergence profile here, and I don't want that to be compromised. I don't want to have to place the implant too palatally just because that's where the bone is. So you can see also this patient's got impacted wisdom teeth. They're horizontally impacted and they need extraction.
Yeah.
This patient actually, on further questioning, the 4-8 was symptomatic. Mm-hmm. And you can see there's a little bit of bone loss there. There's some chronic inflammation. There's a risk of, there's probably even a bit of decay on the distal of the 4-7. I'm not sure, but certainly that's that's indicated for extraction. So I said, well, we'll take your wisdom teeth out and I will harvest a block of that ramus, okay, and put it up to foresight and sort of skewer it in place with two screws. You need a minimum of 2 screws. So we're killing 2 birds with 1 stone. That bone is going to go anyway. So I'm not creating any more morbidity. And even if I were, that's, every case is different, every patient's different, but certainly I always look to the ramus first. If there's not enough bone at the ramus, I'll look at the chin. And anyway, so I did get a CT scan of the rami. So you can see to the left-hand side, you can see the root that horizontally impacted it, and you can see where the inferior alveolar nerve is inferiorly. So really, for me, it's a case of height more than anything. So how much height have I got from the crest of the ridge to the nerve to safely cut the bone with a saw or a drill? So I did that. But it happened to also have a CT of the 2425 side. I don't think I actually asked for it. I think they just gave it to me because they do that. These companies, radiology companies, they just scan everything, even if, which is fine. And actually, interestingly, you can see on the you can see a bit of GP that's come out. That's you can see a bit of GP. But in this particular slice, you can see there is a radiolucency at the distal of the 5, at the apex of the 5. And the patient was asymptomatic. And this is where it's really important, because you have to make a decision about what to do with the 5. So that, if you place an implant in, 6 months' time, if the 5 fails, the patient doesn't go, well, why didn't you tell me? You're not fighting fires. You're planning ahead. It's really important. So I discussed it with the patient, discussed it with the dentist, and both agreed that they would just monitor it, because we're not treating a patient on the basis of their X-ray. We're treating a patient on the basis of how they are clinically. And the tooth had been stable for many years. So I said, okay, fine, we'll leave it. But as soon as you feel, and I felt comfortable that the apical infection, potentially, if there were any, would be away enough from my implant to not affect it, because it's kind of pointing more distally. So that was the other consideration, because you don't want infection at your graft site, and you don't want infection, around your implant. So I did the bone graft, and then when he came back 3 months later for me to remove the screws, the 5 was symptomatic. So rather than place the implant at the 4, I basically just took the screws out and I took the 5 out, and that little cyst came out with it. So I was really glad that I did that. I let that heal, and then he came back and I placed both the 4 and the 5 implants, 2 separate implants at bone level, at the same time. And I discussed with the dentist, are you going to be doing 2 single tooth implants, or are you going to split them and do a 2-unit, a bridge? An implant retained bridge. And I think they decided in the end they were going to do 2 single implants, which is fine. And there are benefits to either of those. You can argue the risks and the benefits of both. But that was their preference. So
okay. So I mean, that's a really good overview. So I guess for the purposes of the audience listening, let's assume this case has come back. Now you've taken the 5 out. The block graft has kind of healed. So now you're looking at a patient coming in with an edentulous 2425 site with good bone, because most of the listeners aren't going to be doing block grafts and kind of that kind of stuff. So so the patients come back now. It's 2-3 months later, everything's kind of healed up. Let's talk about maybe your flap design and what the surgery was then from start to finish in the placement of the implants.
Okay. So let's assume that the site isn't grafted at all, because essentially, if you can preserve the papillae on the distal of the canine and on the the mesial of the 6, and just do an H flap, so you just do an incision across the ridge, and then just a small incision on either end, like a stop cut, then that's quite nice, because you've got enough access and visibility. You can extend the H, the sort of the stop cuts into the buccal sulcus if you want to, but you're preserving the papilla and the attachment on the adjacent teeth. So that's quite nice if you can do that. If it's a bit tricky and you're a bit unsure and you don't want to make that little cuff of tissue too thin, because you can potentially devascularize it, it's okay to include that in your flap as well. So you can do your incision can go all the way right up to the canine, right up to the 6, include the papilla. So never split the papilla. You either include it or you don't include it. So along, and then you do your relieving incisions. If I can get away with a single relieving incision, I will. If I need a relieving incision, if I'm concerned that there's going to be a need for guided bone regeneration, then at both sites, then I will tend to do my relieving incision in a controlled way that's sort of, you've got to really try and sort of diverge the incisions so that you maintain the vascular pedicle to the narrowest part of the flap, which is at the crest of the ridge. And so that your incisions are away from where you're grafting. You don't want your mucosa to be laid down on top of where the graft is.
Yeah. So on that incision on the ridge, are you going more like palatally just for that access point, or where is that? Is that just right down the middle of the ridge, or?
Oh, it depends on where the keratinized tissue is. You want a nice healthy cuff of attached keratinized tissue around each implant. So I don't want to over, usually just on the crest, sometimes a little bit more palatally, because you tend to have a little bit more tissue there, and you can borrow it. So bring it across so that when you close, you then have more sort of tissue on the keratinized tissue on the buccal aspect. And that's important for aesthetics as well.
Yeah. So an ideal case in something like this, you would try and preserve the papilla, cut just, inside of either papilla there, make an incision across the ridge, plus minus, like some releasing incisions on the sort of buccal sulcus of it. If you're doing one, is that generally like mesial, so that just for access, or?
Say that again. What would be mesial?
So if you're doing one like relieving incision, would you put a mesially or distally normally?
I would actually tend to go distally for aesthetics, to be honest.
Okay. Yeah.
But then, yes, if I have to make it, especially if one has to be longer, then I'll tend to extend the distal one. It does end up having to be a bit longer maybe, but it's less cosmetically critical. So, it really depends on it depends on the situation really. But in this particular case, if there's no need for further grafting, your flap can be really minimal. I do like to raise a flap though. I think that it's the safer way to do it, because if you do end up needing to do a little bit of grafting, then if you've got a flap, then you have a lot more flexibility. And I always, 99% of the time, my implants are 2-stage implants, so I will bury the implant. Because for me that increases the predictability, and it just my level of comfort. And so I would tend to do that rather than, a sort of a flapless operation, or doing it, by punching using a tissue punch, for example. Now the reason I give for essentially, if you're doing it as a single stage versus a 2-stage, it doesn't make it any quicker. You still have to wait for those 3 months. Biologically, it's 3 months for mature bone, essentially, and full osseointegration. And you're not going to start loading the implant earlier than that, if you want it to work. So rather than have an implant sort of just a healing abutment sticking out through the gingiva, being constantly traumatized, getting dirty, attracting plaque, potentially compromising the osseointegration, I'd rather just bury it. That it's the same as any orthopedic principle. If things move, they don't heal as well. The healing is less predictable. Like in a bony fracture, you're more likely to get a non-union or a fibrous union that becomes infected if the bone is moving. And any micro movements, I feel really uncomfortable. That's just me. I'm quite conservative, and it's for the patient, there's no increase in time, and it's just a bit more work for me, but it just means I can sleep at night.
Yeah. So I guess we'll just finish this thought before we go on to the next one. So what do you do after 3 months? Do you do like do you do a punch at that point to expose it, or how do you expose the implant after the 3 months?
Depends. It really depends on the soft tissues. It depends on the thickness, the contour. If the contour is, perfect, for as though, the tooth can literally just fit in and it's just sitting beautifully, then I would consider a punch. But more often than not, then that's not the case. And you have to consider doing a little bit more soft tissue work at the time, which would be borrowing keratinized tissue from the palate, for example. And so that's another opportunity to do that and to augment your buccal tissues. So I would then just make a little incision bring the tissues across. No excessive stripping. You don't particularly need relieving incisions at that point, but just enough to be able to see your cover screw, remove it, and then place a healing abutment without trapping any tissue under the healing abutment as you're placing it.
Yeah. So you've raised the flap, you're ready to place the implant. What percentage of your placements do you do freehand versus guided?
I'd say I do perhaps 90% freehand. I've done a few guided recently in situations where very, very thin bone, the volume's not sufficient really to give me a little bit of leeway, and the nerve's right there, the inferior alveolar nerve, for example, where, so, there's just one sweet spot. And particularly if I am taking the patient to theatre, for example, the couple of cases that I have done have been GA cases, and I've actually used M-Guide, the MIS M-Guide, because I feel like that just gives me the accuracy that I need. I find that some of the other guides will, yes, it will give you a pilot hole, but that's pretty much it. So you might as well just do it freehand, to be honest, because it's only really giving you the point on the crest that you need to, enter the crest. It doesn't give you anything about the angulation, the inclination. So to me, what's the point? I'd rather just do it freehand. But certainly with the M-Guide, you can control all those other factors more easily. So that's when
and do that. So in terms of the preparing the implant site, any key tips or tricks or anything that you think would be valuable to share?
Preparing the site?
Yeah, just the osteotomies, just getting ready to place the implant.
Oh, as in, okay, so doing the osteotomies, you get a real feel for the quality of the bones, the density of the bone as you're doing the osteotomies. I always harvest that bone, if I can, with a bone catcher in case I need to regraft it. Often I will just do a little bit of patchwork or just put it on top of the cover screw. Makes me feel good. And then it's a real nuisance because I come back to take the cover screw off and I can't get to it. I have to chisel the bone away. But that makes me feel like, oh, this is a good implant, they've healed well. But what do I do? So based on that, you get a feel for how much you may need to under prep the site, or really make sure that you're prepped to the maximum diameter that you can. If you've got the hardest bone for me, I think the bone that's the most precarious is the really dense cortical bone that has very little blood supply, where you've got cortex against cortex like this. And the crest you've got to make sure that you really cut the crest well, because often if there's anything that's going to hold you up, it's that crestal bone. So you'll end up having to back the implant out. And if you've got a cutting implant, the more you try and place it and then back it out and place it and back it out, you're going to really make those threads less sharp, so they're not going to cut into the bone as efficiently. So your primary stability is going to be compromised just from that. So bearing that in mind, so make sure that sometimes I'll over prep just the crest, knowing it's going to be a little bit, that's not the key area for primary stability anyway, but it just means it's not going to hold me up. So depending on the implant company, they have different sort of maximum diameters that the drill bits go to for the diameter of the implant. And, depending on the system that I'm using, I might sort of over drill a little bit, or just to make sure that I don't, that I'm not overly compressing the bone as the implant is placed. I don't like to finish off my implant placement with the hand wrench. I like to be able to place it at a maximum of 50 Newton centimeters with the implant motor. So if I'm having to really torque it down, that makes me really uncomfortable. And if I feel that's going to happen, I tend to just stop, back out the implant, and then re-drill. Depending on the system, so the MIS implants are great because they cut in. Some of them don't have cutting threads. I'll always tap the osteotomy site, because those implant systems, you just can't rely on the implant to help you, and it's really important not to undercut the osteotomy. I'd rather have an implant that didn't torque out at 15 Newton centimeters that I'm going to bury, so the primary stability is not as great, versus one that I really have to torque down, because that's much more likely to fail because I've overheated and overcompressed the bone.
Yeah. So it's interesting because like some people prefer to like, hand torque it in at the end, or so what made you kind of decide to do it? Is it just from like your own personal experience, or?
Well, not. I think I just get very nervous. People talk about like crestal bone loss, early crestal bone loss, or just implant failure. It just within the first 2 or 3 weeks, the implants failed. And I mean, that's never happened to me, not yet, touch wood. Yeah. And I feel like, I'm not saying that I'm sure it'll happen at some point, but I just feel like that we underestimate how much heat that compression process generates, and how much overcompression can potentially kill the osteocytes and impair your osseointegration. We talk about primary stability. We know that's really important for the the better the primary stability, the more likely you are to have secondary stability. We know that that's been proven in the literature, but that's within reason, right? So no one's ever talked about how much torque can you get away with. Yeah. And I think you start using a hand wrench and you're going, to 70, 80, even 90 Newton centimeters. I just get really nervous about that.
Yeah. So you try and cap yours at 50 with your placing with the Hades, with the motor.
I might just do one. If I just had to do a tiny little turn with the hand, I would do it because I don't want to back out the whole implant. But certainly, so it's about thinking. So as you place your implant, you're feeling and you're thinking. If you feel like, it's got that kind of resistance as it's going in and it's not quite, you just feel like it's literally that feeling like it's about to torque out, but you've only just started placing the implant. Don't just keep going. Stop, back it out, re-drill. Yeah. Don't just idly go, and then I'll just torque it right down, because people get very nervous and they don't, especially if the patient's awake. You don't want to be seen to be, taking out the implant and placing it again. And gosh, what are they going to think of you? Don't worry about any of that. Just make sure you do the right thing and think about, why it is that this implant just is, is tougher to place than it should be.
Yeah. What percentage of your implants would you say you'd place under local versus general, like just like a single unit implant?
70% local.
Yeah. Okay. So it's not, so people shouldn't look at not being able to do GA or some sort of like IV sedation or something as like a hindrance for simple like single unit cases and things like that.
I always say to patients, it's no more, actually taking a tooth out is probably more traumatic. Psychologically, having the implant placed is not as traumatic, and certainly it's less painful. It's less painful afterwards, but it's also, I don't know, it's sort of a reconstructive thing. It's not, you're placing something. And so it's definitely not that big of a deal. For me, and I say to patients, there's going to be a lot of opening and closing. I'll be drilling, stop, check, put my direction indicator in, check the a position of the implant, check against the opposing dentition. There's a lot of opening and closing, and I warn the patient of that. So and they're all like, oh no, we're very grateful that you're taking your time to make sure the position is perfect. But that's really important. I find that easier actually when the patient's awake. When the patient's asleep, it's a little bit harder to get that. Obviously, you have to have a nasal tube, so that immediately makes it a little bit more invasive, I suppose. But yeah, so it's just a bit harder because they're sort of lying flat versus semi-recumbent, and you try, if you've got to make sure you get them in the right occlusion so you can work out where the teeth meet.
Yeah. So you do a fair bit of teaching and things around implant dentistry and work with a lot of people kind of just starting out. Is there anything that's important that we haven't touched on, you think, or any other kind of advice that you have that people could find useful before we wrap up?
I think we've covered I think we've covered the main things, which are treatment planning, but not, overall treatment planning, and looking at the whole picture, looking at the teeth, adjacent teeth, looking at the opposing dentition, definitely the opposing dentition, and really focusing on, the restorative space, because, I'll sometimes get referrals from dentists and there's absolutely no restorative space. So it's all very well, I can place an implant, but where's the crown going to go, for example? And then just looking ahead, particularly if you've got anterior mandible teeth that are beginning to fail. thinking about the long-term prognosis of the whole section rather than just one tooth in isolation, because they can be quite tricky implants to place and to restore. And you want to sort of just make sure that you're taking the whole sort of site into consideration and not just the implant site. But I think we've covered everything. And I think imaging is really important, remembering OPG always.
Yeah.
And CT scan is not a substitute for clinical examination.
Yeah, that's good advice. No, I think that was definitely great. We covered a lot of topics in terms of different flap designs, preparing your osteotomies, placing. It's interesting that you do like the 2-stage, like bury them versus kind of having the healing abutment there from the start. And I think definitely for people starting out, that's probably the more predictable way of doing things. So even though it may add like a second, the argument is like the second surgical kind of procedure to expose it and things, it may be worthwhile just to get that predictability in the actual implant placement and some like long-term success. So I think it's definitely a good approach. The freehand versus guided, I think is going to be a good debate going forward for people starting to place their first few implants. Like doctor, I think there's like the muscle memory component of it, or reducing the overall variability. And obviously with someone like yourself with like the experience and things, you've already naturally got that less variability than like someone like me would have like placing my first few implants. So I think it might be worthwhile to start with guided and then maybe potentially go with freehand.
I think that guided implant placement is just revolutionary, really, and I think it's great. And there are situations that I mean, it's great. What I would suggest is do a few guided, okay, and learn from that. Don't just do it and close up, because it does speed up your treatment time, obviously. Do it and take it out, look at the osteotomy, put the direction indicator in, look to see how it's emerging from the ridge, to see how it, so almost pretend you're doing it freehand and take that time, because you'll learn so much from that, so that when for some reason one day you come to place one freehand, you'll know exactly how it should look, Yeah. And so I would say do some guided and then maybe do a couple non-guided and see, or even, if you're game, have a guide, do it freehand, but then just compare it. I don't know, but you've got to push yourself to progress, because one day you'll have a guide and for some reason something will go wrong and it won't work. And then you will have to improvise. And that's happened to me as well. You just have to make do with what you've got. And you can't just, particularly if patients are asleep, I can't just walk away and go, well, I'll just wait for it to heal and come back. I have to finish the operation somehow. It's important to have those skills, absolutely, but perhaps not when you're starting off. But I would highly, recommend that you use it as an opportunity to think and to learn, and not as this is great because it means I don't have to think while I'm placing an implant. It's a slam dunk and it's easy.
Yeah.
But it's revolutionary, and I probably will start placing more guided, just because it does speed up. It means less chair time for me, which is great. I can see more patients, which is, I'm very time poor, so
that's a good problem to have. Any other like last minute advice or anything like that, just in general, for anyone kind of starting out in surgery or implant dentistry, and any like kind of the mindset of it is quite important as well, to have like the confidence to back yourself and things, to kind of, like you said, to get grow out of your comfort zone, try things to get better. Any other kind of last minute tips or anything?
I think don't be hard on yourself when things don't work, particularly if you're taking out a tooth. It's happened to everybody, and that's how you learn so much from complications. You learn so much from things not working, whether you're a maxillofacial trainee or a consultant, or even just, a dentist, a young emerging dentist. So don't be hard on yourself, and, have someone that you can pick up the phone to that you feel comfortable with, who can give you some advice. I think that's really important. We're all here to support each other, whether it's your local periodontist or oral and maxillofacial surgeon. People will send emails to me all the time going, what do you think about this? Or send me a text message and go, I was thinking of this. Can you do it? Is this appropriate or not? And I think it's all about communication, and pushing yourself and practice.
practice. Awesome. We'll leave it with that. Thank you so much for coming on and sort of sharing your experience and knowledge with the listeners. I think it's going to be a popular episode within the mini series that we're doing, because it was filled with a lot of good information. And so if you're listening, we talked about some imaging and stuff. I'll put the link in the show notes, and otherwise you can kind of just watch it and follow us along as we had a chat about it. Thanks again, and enjoy the rest of your weekend.
Thank you for tuning in for another episode of the Noobie Dentist podcast. Please be sure to subscribe and head over to iTunes and give the show a 5-star rating. For all show notes and to access all previous episodes, head over to www.noobiedentist.com. Have a great day.